thank you. I don't remember the first time that we came here. It's a few years ago. So I'm so happy that you were able to reorganize this meeting with Adnan, like we used to have every year. So I'm happy to co-chair with Fernando and Adnan this session. So please.
I'm also very happy after 4 years, almost 4 years. It was 2019 when we met for the last time. But he didn't wait for October, so he advanced in 3.5. Now this is a great opportunity to see each other, but also to speak about a big subject, increasingly more important subjects such as drug-coated balloons.
Okay, so thank you very much to everybody for coming here once again. And let's start with the first talk, which is from Dr. Castrati, who is going to talk about these very high pressure balloons.
So thank you very much. It's a pleasure to start this session. May I have the slides? Yeah. Okay. Calcified lesions, it's a great challenge for every interventional cardiologist. We know that for many years. I have shown here the data from a series of 5,000 patients. They are part of 2 randomized trials, and this is a publication in your intervention. All of them got second generation drug-eluting stents. I just excluded those who got Cypher, and that's why they are less than the total number of the 2 trials. You see here what severe calcification and moderate calcifications is meaning in terms of prognosis. They have much higher mortality rate, and especially after the first year. They have much higher reintervention rate, especially during the first year. And after that, the differences are less significant. So this is what we see in intravascular imaging, the 2 methods that we use, IVUS and OCT, and you see the different location of and the different diffusion and distribution of the calcium in the coronary vessel here. Why it is a challenge? It is a challenge not only technically, but also because it increases the rate of failure of stent delivery and expansion. It may damage the drug-eluting stent polymer coating during delivery. And there is inadequate diffusion of drug through extensive calcium arcs. And this probably involves not only the drug-eluting stents, because we are today and tomorrow speaking more about drug-coated balloons, but this involves also drug-coated balloons. And that's why it is impaired effectiveness of drug-eluting stents, and it is increased risk of stent thrombosis and restenosis. We don't have enough data to say something about drug-coated balloons in this area, but they are coming for sure. My topic is about the super high pressure balloon, OPN, NC balloon, and you see here what this balloon is looking, and you have here the balloon. But what is very interesting here is the profile. Entry profile is very, very small, 0.016. And if you compare with, for example, angiosculpt or NC alpha, it is smaller than that. It is also smaller than for the NC balloon from Abbott, for example, NC Trek. And this increases the rate of success with this balloon. What is very typical for this balloon is the twin layer. That means there is a double layer of membrane for the balloon, which makes it very resistant to the high pressure. You see also in what diameters it is available, from 1.5, even 1.5 is available here, up to 4.5 millimeters, and the balloon lengths are from 10 to 20 millimeters. What is special for this is the special inflation device. You see here, now, from 2 years now, we have 2, not only the standard one, which allows up to 40 atmospheres, but also a special one, which allows for 55 atmospheres. And if the patient hears the numbers, what are you doing here? He's saying that with the 40, what is 40? 40 is the atmospheres of the balloon. Terrible. So they get afraid from this. In reality, this double layer and this resistant membrane there allows a very, very high success rate, a very low rupture rate in this, for this balloon. And as a rule of thumb here, I would say we have to use balloons a little bit smaller than the vessel size. 0.5 millimeters smaller is the usual rule here. And also, I would say, use the minimal pressure required to crack the stenosis. So you go gradually up and not immediately to 40 and 50 atmospheres by increasing gradually pressure at 5 atmosphere increments. What is the reality in our center? We are using between 10 and 20% of our cases are with the use of OPN balloon. This is a case here. You see immediately the high calcium content in the CT scan. And this is, it is enlarged. This is what the vessel looked at the time of intervention. We used a microcatheter. This is turnpike, just to go through the stenosis, because otherwise it was impossible. And we used rotablation. You see the blur there. It was impossible to get through the stenosis to the diagonal branch. It is an intermedius branch. So we had to use NC balloon, 3 millimeter at 24. This is the allowed, and it ruptured, you see there. And after that, we used an OPN NC balloon, 3.5, 10 millimeter long, at 35 atmosphere. 35, you'll see that it is very often used because the other inflation devices we have, the standard, allow up to 35. So we don't need to open a new one. Only if we need more than 35, so we go by using what we have on the table. And then if it's not enough, we go for the new inflation device, the special inflation device that is from the same company as the balloon. After the use of OPN balloon, it was possible to go through and to wire the first diagonal branch there, because circumflex is occluded in this case. And again, an OPN balloon at 35 atmosphere. And then we put a stent, a drug-eluting stent, a veronemus-eluting stent, 38 millimeter long. Again, 4 millimeter OPN balloon at 30 atmosphere this time. You see that we are not so courageous to go immediately to the highest pressure. And this is what the vessel looks after all this. I don't know how long it took to do that. So the cases will be shown also after. I will concentrate now on the studies we have done and we are doing with the OPN balloon. This is the ISAR calc. You see that all these studies with calcification are relatively small studies because it's not so easy to do them, to perform them. This is the ISAR calc, is published 2020. It is a small study with 37 patients per arm. And here the comparison was between this balloon, OPN balloon, super high pressure balloon, and the scoring balloon. All the patients used or got biodegradable polymer veronemus-eluting stent at the end. And you see here, OCT imaging was done for the primary endpoint analysis, which was, I will show you the results, and was the eccentricity index in this case. And we had also for them a 30-day follow-up. These are the results. You see the severe calcification was almost of them in both groups. And maximal pre-dilatation pressure was 34 in the group of the OPN balloon and 70 in the group of the scoring balloon, which is highly significant, but this was the design of the study. Residual dissections were in about 10% of the cases without any difference in both groups here. Maximal post-dilatation pressure was comparable between them. So what we achieved during the pre-dilatation, then it was not needed more for post-dilatation. Rotational atherectomy was required in 8% of these cases. Here are some clinical outcomes. It's a very small group, so you cannot say anything about that. But procedural success was 100% with the OPN balloon and about 90% with scoring balloon due to you couldn't cross the lesion with that. And here there are in-hospital MACE and target vessel MI, everything you see at the end, that there are no significant differences, but there are some signals in favor of the OPN balloon. Coronary perforation happened in about 2.7% of these cases. Here are the main results for the study. Stent expansion index was not significantly different, although there was a much higher pressure used with the OPN balloon. But there are some other angiographic parameters that also were in favor of the OPN balloon. Here you see the diabetic stenosis post was lower for the OPN balloon, and also the minimal lumen diameter, it's clear that they correlate with each other, is higher with the OPN balloon. The second study that followed this is the ISAR-CALC-2. So in the last 3 years, we had also the experience with 4 or 5 years with intravascular lithotripsy, vascular lithotripsy. And that's why it was obvious to look at the comparison between OPN and this new technology, which is made available in the cath lab. This is a little bit bigger, but anyway, it's not a big study. 80 patients in total, and they were randomized between OPN and shockwave with OCT imaging at the beginning, and also after the use of stent implantation here. You are allowed, but it's not, you have to do also improvement in the procedure. And at the end, we have final angiography for primary endpoint analysis, which is, in this case, MLD, minimal lumen diameter. It is a secondary endpoint, the OCT-based endpoint, which is also here the expansion index, as in the study before. But we have seen no big differences also in other studies in the stent expansion index, so that's we added this MLD as a primary endpoint. So this is all what I have cases here, but I think that there are other colleagues that are showing cases. So thank you very much.
We can have some discussion also between the cases and the presentation. So thank you for this snapshot on how to manage calcifications. I have a couple of questions, then I will ask also the panel. Do you have questions for Professor Castrati? Please go. I will follow.
Excellent presentation, but don't you think that it's not only the calcified lesion, it's the patient? So the increase in mortality is due to the patient is diabetic, chronic kidney disease, so it's complex, the whole patient.
This is a parameter which shows that the patient is a high-risk patient, for sure. It's not, the high mortality is not connected directly with the calcified lesion, for sure. But it shows that you have not much room with these patients. So they are very high-risk patients, they have other problems, so, and you have to spend a lot of time with this kind. So the renal failure comes after that, etc. You have to to take into account that you have to do not only with a calcified lesion, very complex lesion, but also with a very disease-ill patients in this case. Sure.
Please.
Excellent presentation. Just a question regarding intracoronary imaging with this high, very high pressure balloons. Is it mandatory? Because I mean, it's scary to inflate up to 45 atmospheres if you don't really.
So ideally, yes. We have not used it as a standard. So we are using OPN, this super high pressure balloon, without routine performance of intravascular imaging. Because the problem here is, so as I said, they are very ill patients, and to do OCT in this space you need also more contrast. And the challenge here is also with the lesion, with the crossability of the lesion. There are many problems, so you don't have so much time to lose with that. We have used it, but not routinely. I may say. So it is not a must.
But you tend to undersize them a little bit?
So today you have a very good quality of imaging in the cath lab. So that's the probability that you make a big mistake in the sizing of the balloon is very low. But this is our practice. We are using more than 200 per year OPN balloons, and probably less than 50% of the cases get imaging, intravascular imaging.
And Adnan, I've always had this question because we have a quite good experience with IVL, but not so much with OPN. We use it, but we don't have your experience. So while we are waiting for the results of ISAR Calc 2, hopefully we will have it, I don't know, maybe this year or the next one? Or
we have so far 10 patients only because the other centers are initiated, but have not started yet. We expect that it will be much more now with 6 other centers being
So
involved.
you're in the setup phases
for sure,
first.
yeah.
Okay. My question is, when we have these nice calcifications, 360 or 270 thick, so we need one of these two devices for sure. I believe that a scoring balloon is not, we have seen from ISAR Calc 1, but we know that scoring balloon is not enough for this type of lesions. How is, in your experience, the difference, which is the difference among the crack done by IVL versus the one done by OPN balloon, if you have some information on this?
Sure, we have information, and for me, OPN is stronger. You reach much more. I had a case in my computer at least, so I cannot show it as a good example because I didn't see that the lesion was not cracked in one projection. The NC balloon was dilated normally, and I decided to put a stent there. When I moved in another projection, in the middle was not opened vessel. So after that, I decided to do IVL. But it is with stent inside, which is not the recommendation to do that. You should do it before. But I thought, let's try. I have tried also other times, and sometimes it worked. It didn't work. I let the patient go home and got it back in 6 weeks for another lesion. And I said, now I'm trying with OPN. It went very well. So this is my experience, but it's not the perfect experience because IVL was used in the presence of the stent there. I don't know how much does it interfere with the ability of IVL to open the lesion. But this is, it was very clear, OPN, perfect.
So you believe that OPN is a little bit is stronger than IVL for cracking the calcium?
So I cannot say, as I said here, we are not doing routinely imaging. Maybe imaging guidance may help us to say, here is OPN better, here is IVL better. We don't have this experience.
Yeah, not so far. Thanks. Fernando.
Any question?
Yeah, I have a question. So randomization was performed if the balloon could cross but not delay the lesion.
Not delayed,
Oh,
exactly.
That's
Yeah,
it.
yeah.
And did you find a difference in the profile of both devices? Or
Scoring is, I said before, scoring is bigger.
and in relation could grow?
Yeah, it was
both of them?
10% was the failure rate with the scoring balloon.
So there were not failure in
yeah.
crossing any of those.
First, you have to get in.
Yeah.
So for the device to be successful, first it has to get in.
Okay.
And with this profile, what we have with scoring balloon. But on the other side, it is also intuitive. I don't think that scoring balloon with all these wires there is strong enough to crack every kind of calcified lesion. I have very good experience with in-stent restenosis, for sure, because it's much softer, the tissue there. We try, but it's not the last resort for us, scoring balloon. So we go to other devices for that.
What percentage of patients who you didn't get a full expansion at 30 atmospheres, did you get a full expansion at, let's say, 50
Sure,
or 60?
yeah.
How,
We have.
what percentage?
So I would say that to 50, maybe it's less than 5% of the cases.
Okay, so most of the patients...
So most of the patients get with 35, as I said, due to the utility of these devices we have on the table, and that's why it is the most frequently used pressure, even with OPN. But otherwise, 40 atmospheres is very successful also.
Okay, thank you, Adnan. Now we have the response by IVL, so we have to do an exchange in the program because we have Ziad Ali from the US who is ready. So Ziad Ali, let's see which is your experience with lithotripsy, and if you agree. I don't know if you had hi, this is Bernardo. I don't know if you have the chance of listening to Adnan's presentations and to the following questions. But let's see, what do you think about the comparison between IVL and OPN?
So I'm going to have to respectfully disagree and say that all things aside, especially money, there would be no reason to do lesion preparation with any other device than intravascular lithotripsy other than uncrossable lesions, which is somewhere between 5 to 8%. And I'll show you the evidence for that. And then we can have an interesting discussion. It is important to note that I do have a disclosure. I helped develop the technology, for which is one of the reasons why I'm so passionate about it. So as you know, this is the problem, right? The calcium, it impairs your device delivery. It can damage the stent, damage the polymer. And probably the worst thing that you can do is actually deliver the stent and then leave it in a severely underexpanded format, making it a risk for stent thrombosis and, of course, clearly target vessel failure. In 14,000 patients, we identified moderate to severe calcium as a very high hazard, less than only in-stent restenosis as CKD for 1-year target vessel failure. So let's take a look at why calcium is a problem. Well, first of all, in the pre-PCI setting, if you look at the calcified cohort and non-calcified cohort, in the non-culprit lesion in prospect, actually the calcified cohort does a lot better. And the reason, of course, is because it's stable CAD. You really can't have a plaque rupture in significantly calcified lesions, and really the lipidic plaque is what leads to the events over time. The problem is, as soon as we start to put in stents, now, these are the limitations of the existing technologies. When you have balloon-based, you have an insufficient force. When we perform atherectomy, we have a severe wire bias, and laser, which is focused energy, really is unpredictable and uncontrolled because the amount of energy that's delivered really can't easily be controlled, especially when you deliver contrast and create a cavitation bubble. So along comes IVL.
Okay. So now this is still the low energy, but we're going a little bit higher voltage.
So this is the first IVL experiment that we did in 2009, just down the road from Stanford University. This was all equipment that was bought from eBay and so forth. And we found that the optimal model here, after trying seashells, was eggs. And the eureka moment here is you will notice that the inner membrane of the egg is completely intact and the outer hard shell is completely broken. And really no other technology can be this soft on soft and hard on hard. And now, of course, 14 years later, we have IVL, which delivers approximately 50 atmospheres of pressure using a balloon-based technology, but very importantly, at only 4 atmospheres of dilation. Intravascular lithotripsy does not perform dilation, it performs lesion preparation. And this is an important distinction against other technologies which inflate at very high pressures and thus injure the vessel wall. Remember that focused energy, or laser, will create energy specifically in one direction. But unfocused energy like IVL creates unbiased energy delivery into the artery wall. So it doesn't really have any directional effect. And you'll also notice that IVL gives us about the right energy that we need to modify calcium, approximately 50 atmospheres. The penetration depth is approximately 3 to 7 millimeters. And you'll notice that there is a very low negative pressure, and that's important. And this is one of the reasons why the risk of IVL is very, very low. Now, these are the mechanisms of fracture, which is different to just a regular balloon. You have compressive forces, shearing forces. When the shock wave hits the back wall, it actually creates a spall stress and pulls the calcium inwards and finally leads to a squeezing stress. So there are many different mechanisms simply than applying pressure on the wall that lead to fracture in this case. And what I'd like you to think about is the concept by which a balloon creates a fracture. A balloon creates a fracture in one dimension. So this is a patio at my home, and you can see that there's a fracture. And if you were to stand on these 2 plates, the compliance of this patio will be unchanged. But when you use intravascular lithotripsy, you create multiple fractures, fissures, cracks, which completely change the compliance of this calcification. So the mechanism by which IVL works is like a karate chop. It's a very sharp energy that's soft on soft. But on the contrary, an ultra-high pressure balloon works by fracturing but also tearing, which activates many different genes and response elements to promote neointimal hyperplasia. You'll notice that on micro-CT, unlike getting one single linear fracture by a balloon, you have multiple chips and cracks in many different directions. And we recently showed that OCT misses approximately 50% of fractures by IVL that we identify on micro-CT. So IVL is soft on soft. It's like hitting a hammer with a pillow on the intima. But it's very hard on hard, so it can crack the glass and plate without creating much vascular injury. And that's why you can hold this. Put your fingers on the IVL balloon without any issue whatsoever, and there is no damage to the soft tissue, because the impedance of your fingertips is about the same as the impedance of water. And the way that this works is completely unbiased. It's circumferential energy that goes into the vessel wall without dilation, like a karate chop. The emitters are diametrically opposing, which means you get a very large field effect. It doesn't have to be immediately across from the emitter, so you can actually have energy around the balloon itself. And by doing so, what we can do is move the balloon around the calcium and deliver shocks in multiple places, minimizing the risk of dissection, but maximizing the benefit of calcium fracturing. And here's an example of, you can see that right away, almost immediately at 4 atmospheres of pressure, the balloon starts to yield very, very quickly. So the concept, unlike a non-compliant or ultra-high pressure balloon, of breaking the plate, IVL actually just leads to cracking of the plate, but leaves the plate in its actual same form. It's also important to understand that if you were to go to your child's birthday party, it's almost impossible to pop a 4-atmosphere balloon. Thus, the risk of perforation from IVL is extremely low. But when you start to inflate things at 20 or 40 atmospheres of pressure, the risk of perforation increases exponentially. So let's talk about the algorithm for calcified arteries. Here's what you have. You can smash it using IVL, you can break it using laser, you can grind it using rota, or you can tear it using a balloon-based strategy. And all of these have specific roles in the algorithmic approach for calcium. Ultimately, what we're trying to do is get to a large minimal stent area. So let's focus first on deep calcium and why IVL is a superior modality. This is a case of deep calcium where we use rotational atherectomy. What happens in rotational atherectomy here is you can see it simply tears the pillow on top of this plate, and there's absolutely no modification of the calcium whatsoever. So we're left with a large dissection. On the contrary, when there is neointima on top of IVL, the balloon squeezes the pillow and fractures the calcium. We've removed the impedance by squeezing it with the balloon and delivered the energy directly into this thick calcified plate, leading to multiple fractures. In fairness, laser is also able to do this using the same mechanism, which is the creation of cavitation bubbles. But unlike laser, which is focused energy, the unfocused energy of IVL makes it reproducible and extremely safe. Now, I'm the first to admit that for superficial calcium, we have many choices. Atherectomy is highly effective at modifying lesions and thinning and debulking the plaque. And this really works well when you have favorable wire bias. And in situations like this, you can thin the calcium and then fracture it and push these tectonic plates away from each other so that you get excellent luminal gain. The problem is in situations like this, which we see regularly, where the artery shows severe tortuosity. Now look here at what this wire bias has created. It's basically created a huge gutter in the LAD, which ultimately leads to a perforation, fortunately in this situation contained because the wire bias cannot be managed. IVL, on the other hand, it has been extremely well established that IVL works by creating multiple calcium fractures in severely calcified lesions. The mean number of calcium fractures is 3. And what these fractures do is they facilitate the moving of these tectonic plates such that we maintain the circular geometry, symmetry, without eccentricity, creating to a least amount of eddy current, which of course, as you know, is a risk factor for restenosis. Now you'll also notice, and I would implore you to ever show me a case using a balloon where you are able to fracture eccentric calcium, because the mechanism of lesion modification and eccentric calcification is tearing of the interface of the fibrous and the calcium. However, here you see IVL fractures this extremely thick calcium plate, leading to an improvement in luminal area. We've shown repeatedly that the mechanism by which IVL works is to create circumferential calcium fractures which lead to excellent stent expansion. Now, while I admit that all of these modalities can lead to calcium lesion modification, when efficacy is all the same, there's only one discriminator, and that discriminator is safety. In 561 patients, 0 perforations from the device, 0 abrupt closure, 1 case of slow flow, 0 cases of no reflow, and almost no flow-limiting dissections after stenting. This kind of safety profile is unparalleled in almost any technology in interventional cardiology, certainly for lesion modification by calcification. Now, lastly, I'd like to toy with you about the idea and dogma of nodular and eccentric calcification, for which years we've used orbital and rotational atherectomy. And I'm going to say that the main reason that we use orbital and rotational is a lack of evidence, but a lot of conviction from interventionalists because it makes sense. And this is what we tend to think. We tend to think that if we have this calcified nodule, we'll end up performing an atherectomy and it'll make this huge, beautiful cut, and finally we'll get this lovely stent expansion. However, if you do the math, if this 1 millimeter OCT, a 1.5 millimeter rotational burr is only slightly larger than that. And even an orbital atherectomy can barely impact this nodule. So in actual fact, the lesion modification that you're getting with an atherectomy device is more like this. And what we're seeing by atherectomy is basically a removal of the top of the nodule, whereas in IVL, we're breaking the nodule into pieces. And by breaking the nodule into pieces, we can crumble it and push it out of the way with a stent. So the reason my conviction says IVL is because IVL doesn't hamper by the balloon effect. When you have a balloon in one view, you can clearly see that you can imagine one view it's going to look expanded, but another view it won't. Atherectomy may be wire biased away from the nodule or provide very little atherectomy, but IVL is completely unbiased in its calcium fracturing. But let's look at the evidence. Here's the evidence so far of patients treated with calcified nodules with atherectomy. They have a 3-fold event rate in calcified nodules up to 5 years. So clearly these patients do worse. But when we use IVL in calcified nodule lesions, we found that there was absolutely no difference in the minimal stent area, mean stent area, or the stent expansion at the minimal calcification and maximal calcification sites. So acutely, IVL is able to modify these nodules by breaking them into pieces and allowing us to expand stents. And in the largest cohort to date of any specific calcified nodule cohort, there's no significant difference in target lesion failure at up to 3 years. So I would say that the mechanism of IVL is actually to break these nodules into smaller pieces, allowing us to deform them much more easily. And here's an example of a nodule, which we've all seen often. Once we perform IVL, you'll notice that this nodule is now broken into many smaller pieces. And what those smaller pieces allow us to do is to push them into the artery wall and maintain concentricity and minimize asymmetry. And you can see what kind of impact IVL actually has. So to me, the new algorithm is simply, if you can cross it, you should shock it. The financial implications aside, the optimal lesion preparation strategy is using intravascular lithotripsy, except for the small number of patients in which the lesion is uncrossable with a guideliner, which is somewhere around 5 to 8%. Thank you very much.
Ziad, thank you very much. Beautiful talk. I would like you to stay 5 minutes extra with us. I know that you are having there an impossible day. Thank you for being here with us. Beautiful talk, and as we discussed, very provocative and very enthusiastic, coming from a young guy, right? Now, my questions here for you will be 2 questions. I mean, the hypothesis, the pathophysiology, everything is beautiful. I mean, Adnan was just describing a couple of small yet randomized clinical trials where the technology was evaluated with some success. To me, the 2 key questions, as you mentioned, is, I mean, this should be safer. We don't have data for that. I mean, it appears to be very safe. I mean, it will be safer, but there is not a large trial demonstrating that if you use lithotripsy, you get less perforation than if you use very high pressure balloon. Everything is, you know, in that direction for sure, but we don't have the data. And the other thing, and I will finish that, and perhaps you will have some time for the chairs and discussion to ask. We don't have a randomized clinical trial yet. I mean, a randomized clinical trial in patients with moderate to severely heavily calcified lesions is not so difficult to do. I mean, you can use just conventional balloon and stents, you can use high pressure balloon, whatever. Why this trial is not yet with us? And thank you very much.
Well, I'll start with the last question, Fernando, and that is that, as you know, the ECLIPSE trial, which randomized patients to a balloon-only strategy against orbital atherectomy, took almost 8 years to enroll. And one of the reasons is the dogma and conviction of interventional cardiologists who are not willing to randomize patients to balloon only in truly severe calcification. So while I think in trial logistics or trial development, it's not particularly difficult, it is extremely difficult to enroll these patients from a practical point of view. And then what ends up happening is that the patients who have the most severe calcification end up undergoing lesion preparation, and those patients who are moderate to severe calcification end up in the trials. As you know, Prepare Calc was negative, ISAR Calc was negative, Rotaxis was negative. And if you just give me a moment to talk about why that is from a core lab point of view, it's actually very interesting. So what tends to happen is the minimal stent area in all of these studies tends to end up outside of the maximum calcified area. So the lesion preparation strategies, they go to the 5 millimeters of maximum calcium, perform very diligent lesion preparation, atherectomy, high pressure balloon fractures, and then they put a 38 millimeter stent. And the 38 millimeter stent ends up with its minimal stent area 5 millimeters from the proximal edge. And then that becomes the denominator. And this is one of the reasons thus far none of the trials comparing balloon versus any other modality have been positive.
Yeah, I mean, my feedback there will be, like 25 years ago, we were told that rotational atherectomy was so clearly effective and was respecting soft tissue so clearly that we don't need a randomized clinical trial. And this is why, in the clinical guidelines, rotational atherectomy is not got an indication other than a bailout procedure. But this is just for the sake of discussion.
Yes, thank you, Zihad. We have here a great panel of experts. But before letting them ask you some questions, I want to congratulate you with your fellows that prepare your slides so nicely. So you have great slides. Congratulations. If they are your fellows or if it's you, I don't know, but congratulations. It's you, great. You are great. I will ask you some advices on this. So are there questions from, yes, please.
Yes. So congratulations, great talk. I'm glad you brought up the matter of the calcified nodule because I wanted to ask you about it. And I wanted to ask you if there's some kind of nodule morphology that you would say is more favorable to lithotripsy. And then also about neoatherosclerosis and chronically underexpanded stents in stent failure. What are your views on this scenario?
So let me answer the second question first, which is chronically underexpanded stents. While this is completely off-label, I again would argue that this is the most effective therapy for calcified neoatherosclerosis that's leading to stent underexpansion or in-stent restenosis. So we are preparing the largest OCT-based step-by-step study of in-stent restenosis. We've got 50 patients with OCT imaging pre-post for patients with neoatherosclerosis in-stent restenosis. And again, we show that the number of fractures that you can generate is the most important predictor for your final stent expansion and for target vessel failure. So it is highly effective. Whether the metal's in the way or not really provides very, very little impact on the ability to fracture calcium. Sorry, your first question, which was?
About nodule morphology, if there's any predictors of
yes,
success.
Great question. So as you know, there are two types of nodules, eruptive calcified nodules, which are biologically active, which are like broken glass. Those are not effective using any strategy. And the reason is the broken glass usually happens at a hinge point. And then when you put a stent on it with 18% surface area or coverage, the spicules of that broken glass just poke back into the artery. We just published that 2 weeks ago in JACC Intervention. 20% event rate at 2 years in patients with an eruptive nodule. But in protruding nodules, which as I showed you in the examples, are basically like a marble that stick into the artery wall, cutting the top of the marble or mountain off is not effective. What is effective is breaking the marble into multiple pieces. And whichever modality is the most successful at doing that will best provide the best clinical outcome.
Okay, we have Adnan who has a comment.
Ziad, a great talk for sure.
Thank
Great
you.
great theory. But here we have the practice. We have the experience in my center, at least with hundreds of cases of IVL. Just to tell a story, the rep of the company came and did proctoring for the first 10 cases. At least 4 of these 10 cases needed an OPN balloon at the end. I didn't tell it before. And I said to him, please put it in a set. 1 IVL plus 1 OPN. In order. But what I have to say is, our theory that this perfect result is something important, I don't know whether it is true. It probably, even with optimal result after IVL, you have good results at the end or at follow-up. So this should be shown. And this is the only way to show this is through randomized studies. Because otherwise, theory is perfect, and you have shown it wonderfully here. The problem is what is achieved with IVL without the help of other techniques such as OPN. Is it enough? Is this cracking of calcium without reaching an optimal result enough for the outcome? This should be shown. And just to tell you, in Germany, we are preparing a very big trial with thousands of patients randomized with IVL and other techniques.
I think that's an important point, that there is no better discriminator than randomized controlled trials. But, you know, if we go back to Rotaxis many years ago, it did teach us a valuable lesson, and that was it made the case easier. I mean, in our cath lab, which was the highest volume atherectomy center in the United States, perhaps us and a Sinai, we completely eliminated atherectomy to less than 5% of all of our calcified cases now. We use IVL in almost every case. It's easy to set up. The nurses have no concerns. They don't have to worry about pressures. There's no slow flow. We don't have to put pacemakers in. The procedure time is cut down by 15 minutes. And I should say, Adnan, in full disclosure, we've only very recently got OPN. I've only used OPN in Canada and the UK. So I have to admit, where it fits in the algorithm, certainly in the algorithm that I presented for PowerPoint, I didn't put in because I don't have enough experience. But having said that, IVL is so easy, so effective at doing its job outside of the cost. I simply find it difficult to argue with the safety of this device. And for me, that is, in severely calcified lesions, that is the thing that prevents mediocre or low volume operators from doing lesion modification. And so, you know, Adnan, the truth is you can use any modality and be great at it. That's the fact. You do 500 PCIs, you look at the angiogram, you know exactly what to do, you have a strategy, you have the guideliner in, you have support, you have everything. But really, these technologies are not made for the advanced operators. They're made for the operators that are doing 80 cases, 100 cases, and they're the ones who end up with the suboptimal results. So for the masses, this is easy to use, it's highly effective, and it's safe, which is why I feel so strongly that it's taken such a great hold of calcification.
Thank you, Ziad. I think that for the sake of time, we have to go ahead. So, if you want to remain, it will be a pleasure, but we believe that you have a quite tight schedule. So
I've got a Euro Intervention editorial board meeting.
Thank you.
Thank you, everyone. I appreciate you having me.
So we are going with the third presentation. Dr. Goicolea from Hospital Puerta de Hierro from Madrid is going to talk us about this technology, the cuttings and scoring balloons. He has a large experience from the very the first cutting balloon from Boston to these new balloons like Scoreflex and Wolverine and all this stuff.
So
after bombing, now let's see which is the role of cutting and scoring.
We're going from the teenager, the European, to the newborn, and then we're going to the old guy, because this is an old guy. It was the 90s, early 90s, that we started with the cutting balloon. And of course, it wasn't like this. It was another device. And we had the same problems that we have with lithotripsy, that we do not reach where we want to reach. And occasionally calcified lesions are very difficult to reach. And that is a major limitation with lithotripsy, which is not so with rotablator or even with OPN. So, but at that time we had the problem. And in 95, 96, 97, we performed a trial, and that's just for the sake of remembrance. And Fernando was there with me, and we were working together, and we found this. So, native coronary arteries, no stents at that time, balloon versus cutting balloon, just a very minor difference in angiographic result, but not in TLR. But what was the difference? There were some differences. We used much less pressure, not as low as the lithotripsy, but whereas we went at that time at 9, 10 atmosphere, we were using 6, 7 atmospheres. So, I mean, at least from the intuitive point of view, you would think that lower pressure is less risky. I don't know for sure, because you have to prove it. Adnan, you're absolutely right, and the answer will come from the trials, etc. And this is the way it works. The aterotome incises the wall, and what is new is that it is relatively easy to go even distally, and the mechanism is very similar to the one we see with lithotripsy. I mean, we see, I don't know, but really, I just, I'm not sure. I mean, it's okay to do a cartoon and put a web of cracks and things like that. I'm not sure. Actually, when we do OCT after lithotripsy, or after scoring balloon, or after cutting balloon, we see 1, 2, 3 cracks. What are we trying to do at that moment? We're not just, I don't know, you know, when you go to the couturier and he wants to make you suit, he just makes a cut, and with that cut he breaks up the whole tissue. You don't have to make 100 cuts to make the plaque more distensible. And that's what we see. This is an interesting work by Kinoshita, actually, who is very well known for CTOs. And he put in a silicone tube the cutting balloon, and he inflated it at 9 and 20 atmospheres. And he said what percentage of the aterotome went into the silicone tube as compared to the scoring balloons, whereas other scoring balloons had 19 at 20 atmospheres. 20% of the scoring. The cutting balloon induced a score of 86. This is not real life, this is silicone tube, but you know, it provokes the thought that maybe this old technology could be more effective than we think, just because it is old. However, you know, and we know, its use has been hampered by poor deliverability. It was a rigid device, large profile, low rated pulse pressure, which I don't very well understand. I'm speaking for low pressures, but now I'm asking for high pressures. but in some instances you need high pressures. So I think to have 12 atmospheres is not enough for rated burst pressure in this context, especially in the context of calcium. Small improvement and uncertain and acute results, and we are lacking, despite the time that we have the device which has good long-term randomized control trials. And things have evolved. We have a new blade which is far less deep. This is the old one, this is the new one. The blade actually are divided in 4 sections, and that makes it more deliverable. That's part of the question, and I know that you, well, this is just an example. I mean, you can see this is a very diseased LAD, and you can see how the cutting balloon travels all the way to the end. And remember, to get something there, you don't only have to have a low profile, you have to have good pushability, and this device has good pushability. But we have, we especially like this, Adnan, I can tell you. We have a new kit, not so new, but, and we have other scoring devices. How do they compare? And that's, or is there any, I know, when you put cases, there is a danger. I mean, you to have, I don't know why this will not go. So it's not unreasonable that IFR with this lesion. So we went for it. There are several stents in the LAD, both the 2 over there overlapping and 1 there. We do a OPM balloon with intravascular imaging, and I finished with a papyrus stent. The patient is okay because I received a ham the other day, so I suppose he's okay. I tried to call him, but he wasn't there. So that's the question. I mean, 30 atmospheres. It wasn't 45, 30 atmospheres, but and we looked at it with intravascular ultrasound. Maybe it wasn't easy because it was calcified, but I mean, 2% ruptures or perforations, I think that's something to worry about. So let's look at the facts that we have, at the evidence that we have in all this time. Just, I mean, the cutting balloon can be used in several situations. It can be used in bifurcations, intercoronary hematomas, can be used for spontaneous dissection to open up the distal, and for fistula, but we want to focus on calcium and in-stent restenosis. And the in-stent restenosis, the first trial that we had was versus balloon, cutting versus balloon, no difference, but fewer numbers of, in fewer instances we had to use more than 1 balloon, less slippage, which is also usually important, and what they call watermelon seed effect, less additional stents, and less pressure. So that was, it's old, but it is very important. I think those are the main points that are still true. ISA Desire 4, this is not cutting. This is with a scoring balloon, which is a modified balloon. It uses, I think, a nylon. We don't have it. But there is a difference in diameter stenosis at follow-up angiography, but without clinical benefit, or no really difference in restenosis rate, no difference in death MI, no difference in TLR.
Restenosis, yes, but
TLR was numerically better, but not significant.
Yeah, but it wasn't powered for clinical endpoints.
Sure.
It wasn't
As a
powered.
mechanistic study, it worked well.
It was angiographic study.
Yeah.
But it does show the point, that you can obtain a better result. Of course, you combine it, because until now we have been talking about studies that were balloon versus cutting balloon, and now we are starting to combine the. There are non-random comparisons. This from Taiwan. There are no significant differences, both in event-free survival for 1 year TLR, and this other non-randomized comparison of balloon and cutting balloon for the treatment of wrist stenosis with rocalutin versus bare metal stent. The only thing is a note of caution in this study. There were more MIs with cutting balloon, which I don't very well understand. Neither do the authors, I have to say, because they were up to 30 days. I don't know, maybe it could be yes. What about calcified plaques? What evidence do we have? First of all, we have a study by Matsukawa in 2019, relatively new. Greater acute gain, greater cross-sectional area, and better stent symmetry index obtained at lower pressure. And then we go back to the wrist cut, the old trial that you can work at lower pressures with a more effective scoring mechanism. COPS trial, 2021, there were not many patients enrolled. It's a small study, Italian study, 100 patients, but at the end 87 were included. Basically, the cutting balloon was used to optimize the predilatation for stent implantation. And there's one thing peculiar about this study. Cutting balloon was used at very high pressures. It was used at, I think, 19 atmospheres. The difference were small in favor of cutting balloon, very small. I mean, if you can look at it, really the minimal stent area and the eccentricity index both were in favor of cutting balloon, more so in the eccentricity area with a more compressed box. And I have to note that they were highly calcified lesions, more 100 degrees of calcium. And this is what I was trying to tell you, the atmospheres 18.6, 18.3. So I think this was off-label, of course, but it could be interesting if we, but we have to consider the fact that there were 2 ruptures. There are not many, it's a very limited number of patients, but maybe the combination of cutting balloon and high pressure is risky. Well, I leave it at this point. I mean, this is provocation, but it could be. ISAR calc. Once more, we go to your city, and you talked about it, so I'm not going to say, only to say that the endpoint, the major endpoint was negative. But there were differences. There were differences in diameter stenosis and minimal lumen diameter. However, perforation, 2.7 in both we always have that. We always have that, but this time with both devices, both with scoring and super high pressure. And finally, we can use combo therapies. I mean, why not use lithotripsy and cutting balloon? Why not use laser, category. Why not use, well, combo therapy in this case was rotational atherectomy and cutting balloon. There was a difference in instant acute lumen gain after stent implantation and minimal stent area. So it seems that this could be, we don't have to be exclusive. I think we have very difficult cases and we have to use the best material that we have. Finally, just to finalize, 3 slides of when to use, how are we going to use. We have to intracoronary imaging, I think is important. They are scoring the scores that signal the amount of calcium that we have, both with OCT and with IBUS. And basically, with both the scores, if you are over 2, you have to think, and we'll put the 2 algorithm. This is the one proposed by the Spanish Society of Cardiology. I think it's okay. For you that maybe understand well, they divide in slight angiography calcification, you take it to the normal side, moderate to severe angiography, then IBUS OCT. If the calcium arch is severe, if no, non-compliant balloons, cutting, scoring, high pressure balloons. If yes, lithotripsy, ELCA. And if you are unable to cross with the IBUS or OCT, we'll try to use the OPN or others. I think it's an algorithm. You can make other algorithms. It's a reasonable algorithm. It's well thought of by people that are. Okay, I think this is the end of my talk, and I think we can make a mixture of all of them. Thank you very much for it.
Thank you, Javier. Another very nice talk. I give you my position after having also listened to Adnan and Ziad. You know, I was discussing about bombing with the first 2 devices. I think that now, if we have heavily calcified lesions as seen by intravascular imaging, so thick calcifications, 360 or 270, whatever, I think that there is no role for these devices for any cutting or scoring balloon, because we have very, very effective and good devices. You may decide to use ROTA. If you have experience with ROTA, you may decide to use shockwave or OPN. Also, because the cost is very different. If you don't want to spend 3,000 euro or 2,500, whatever it is, or $5,000 in the US, you may decide to use scoring balloons. But if the calcification is not heavy, I don't think that you will obtain a good expansion in order to accommodate a stent or to use a drug-coated balloon in a heavy calcification with these devices, whereas their role is increasing, and in my practice I'm using them in 30-35% of the cases, but in other different settings, which is the moderate calcification or the very fibrous lesions or some types of ISR. Which is your idea and your comment on this?
Well, ISR was the original use, I think, the selective use for this cutting balloon initially in the final 90s because of slippage of the balloon. And actually, if you see the guidelines, that's what they say. I don't want to give more credit to the guidelines that should be, but I think that's a good reason. I mean, you dilate where you want to dilate, and you have a fibrous plaque that you break it up and you may get a good expansion. As regards to calcium, you've seen what the Spanish Society is very similar to what you said. What the Spanish Society of Cardiology, the group of experts propose, is very similar to what you said, in the sense that when the arch of calcium is not very large, it could be a good idea to. I mean, what you're proposing is never to use it if there is any calcium, if I understand.
If there is a heavy calcification.
Yes.
There, I think that the other two devices, and also atherectomy, with the two atherectomy devices have a higher role, a more important role.
I agree completely.
Also because we have seen from the first slide by Adnan how calcification, heavy calcification is associated also with increased TLR, not only mortality.
¿Podemos poner la última diapositiva? La penúltima.
So moderate calcification, I think, yes, there is a role for this, also because the new generation, as you said, have an improved deliverability as compared to the first cutting balloon. So I think that there is an important role. But if you have high calcification, I don't think so.
Yes, I basically agree with you. If I have the lithotripsy and I think and the rotablator and in very highly calcified, I think I would use those or the rotational therapy.
Panel, any other comment? Do you have different ideas on this?
Yeah, just one brief comment about this. I think, I don't know, it's just, I think maybe the difference is calcium thickness, because I don't agree that you shouldn't use cutting in circumferential, because if you're using it in 180 degrees, what are the chances that you're going to break the calcium? The balloon is always going to go the other way, the soft way. Don't you think so?
If it is very thick.
No, yes, I mean, probably it's not going to work in very thick, but I also think it's not going to work in 90 degrees or 120 degrees, because it has all the soft tissue on the other side.
It may act as a lever to the other side, you know, you push to the other side. But I'm sure we do that a lot of time. What do we do with mitral valvuloplasty? Mitral valvuloplasty, when we inflate the inner balloon and we have a calcified nodule. The force of the balloon goes to the other commissure. So I tend to undersize a little bit there. That we do that. I agree completely with what you said. We have to have the evidence, because in theory, you can say, well, everything is great, we break the calcium, we munch it up in little pieces and everything goes away. But I fear that that is not very often the case. I think that it will act as a lever also to the other side. So that is why I ask you if in those cases, if you do not have intracoronary imaging, and I think you put it in your protocols, undersize by 0.5 the high pressure condoms.
Should we move to the cases now? Yeah, thank you very much. So let's move to the last part of this session.